Welcome everyone to tonight. Welcome to the Julia Argyrou Endometriosis Centre webinar series. So tonight we're focusing on number 5, and that's going to be planning to conceive with endometriosis. Tonight we're going to be joined by Dr. Sam Mooney. We're very, very privileged to have her here with us. So before we jump into that, we want to do an acknowledgement to country. So Epworth Healthcare acknowledges the peoples of the Kulin Nations, the traditional custodians of the land upon which we work and care for our patients. We honour the unique and continued spiritual connection that Australian Aboriginal and Torres Strait Islander peoples have to land, waters and culture. Okay, so just a few introductions tonight. So I'm going to start off with Dr. Sam Mooney, who is our esteemed guest for the evening. Dr. Mooney is a highly skilled obstetrician, gynaecologist, fertility doctor with specialist training in minimally invasive surgical techniques. Her clinical interests include pelvic pain, endometriosis, management of benign pelvic masses, and heavy menstrual bleeding. She is an accredited AGES Level 6 laparoscopic surgeon as well. So many hats that Dr. Sam is wearing. Sam finds joy in providing patient-focused and evidence-based care to women with a range of gynecological concerns. Sam is also a clinical researcher, very active in this field with interest in pelvic pain and endometriosis, hysteroscopic techniques and surgical education. Now, my name is Steph. Some of you may recognise me if you are a patient here at JACE. I have recently joined the team as a registered nurse with a postgraduate in sexual and reproductive health. My area of expertise sort of ranges across women's health. I've worked in sexual health, contraception, IVF, and termination. My biggest passion is basically amplifying the voices of our patient and creating a safe space where everyone feels that they're able to tell their story and be listened to. And then next to me, I have my colleague, Caitlin, who will tell you a bit about herself.
Hello, my name is Caitlin. I've also just recently joined the team here at JACE, which I feel very privileged for. I began my career as a nurse midwife, and I then worked as a fertility nurse specialising in fertility preservation. I have cared for multiple women with complex conditions, including endometriosis, in my career. I previously worked at Epworth Freemasons as a private clinic nurse for a fertility specialist, and most recently I've also taken on an endometriosis research role at Epworth Freemasons. So that's just a bit about me. And now just a bit of housekeeping before we begin. Epworth is proudly inclusive. We acknowledge that not everyone with endometriosis identifies as female. Whilst we aim to avoid the use of the term women in this webinar, we do acknowledge that non-binary, gender diverse and intersex people, and in rare cases cis males, can suffer from endometriosis. Throughout the presentation, you are very welcome to please drop some questions in the chat box as we go. And at the end of the presentation, that's when Dr. Sam Mooney will acknowledge and answer your questions. And just to reassure you, the questions that you do ask, your name doesn't pop up. So privacy-wise, just go for it. Also, at the end of this, all registrants will be emailed a copy of the recording once available, and it will be available on our website later in this week also. So enjoy.
So that's all of our housekeeping done now, and we're going to pass over to Dr. Sam. So please enjoy this presentation. We are very, very grateful to have Sam here at the end of her very busy day. So thank you again, Sam, for joining us tonight.
Well, okay, thanks, Caitlin and Steph, and thanks for that wonderful, warm introduction. And hopefully everyone's sitting down, having had some food, or at least has a glass of something nice on what looks like a nice sunny day. And apologies for my scrub attire. It's been a busy afternoon, but I was told I looked the part, so that's a nice start anyway. And we'll see. All right, I just wanted throughout all this, so I'm currently the acting director of the Julia Argyrou Endometriosis Centre. but we'll pass back to Dr. Kate Tyson as the new year passes over. I do work for one of the Melbourne-based fertility companies, Gynaea, but this talk tonight is initiated via the Julia Argyrou Centre, and that recognises that really lucky in, well, definitely in Metro Melbourne, but also in regional Melbourne, to have good access through a variety of fertility clinics. And so that these slides come from my work in endometriosis, but I do acknowledge that I'm a Gynaea specialist. I work at the university as well. I'm involved in several important research projects and receive funding through the Norman Baisha Research Foundation and the Medical Research Future Fund. In terms of endo, most of you are on the call either because you yourself or a loved one has endometriosis. And I find this quote rings really true for many of my patients, their partners, their mothers, their support people. So women with endometriosis are confronted by one or both of two major problems: endometriosis-associated pain, infertility, or I thought it's going to be a bit of an overview, but we'll focus on firstly what is endometriosis quite quickly and hopefully succinctly. The incidence of endometriosis, I'll go over that, clinical signs and symptoms, and then we'll dive into the impact on fertility, how we investigate this, what management options are available, making this sort of fertility specific for people with endometriosis, and some take-home messages at the end. So many of you will be across what is endometriosis, but we'll briefly go through that. So endometriosis is a chronic gynecological condition that can cause pelvic pain and affect a woman's fertility. The inner lining, called the endometrium, the inner lining of the uterus or the womb, implants itself in the wrong spot, so outside of the uterus. And so it's the same cells that line the inside of the uterus, the endometrium, that deposits itself elsewhere, and we call that endometriosis. Growth of these cells can lead to inflammation, stickiness of tissue, scarring, and that we theorise in one part is the cause of pain, though endometriosis-associated pain is quite a complex and multifactorial symptom. In all honesty, we don't quite know why endometriosis takes place, and it is possible that for many people it is a multitude of causes. When I went through medical school, 20 years ago, the idea was that it was all retrograde menstruation. So it was the endometrium when a woman menstruates, comes out through the cervix, down through the vagina, but some of it goes backwards and out through the tubes. But we know this to be quite a simplistic thought. It's definitely linked and will be the cause in many cases, but it's much more complex than that. It may also be able to travel in the blood vessels and the lymphatic system. It's possible that these were cells sort of sequestered or stuck in a place and they became endometrial cells. And then we've got really a lot of evolving epigenetics and genetic theories as to why endometriosis takes place in terms of the immune system, how our DNA actually works. Endometriosis has been described in pretty much all tissues, though majority does affect the pelvis, though people on this call no doubt have had endometriosis found in other locations. So this diagram is just showing common places in the pelvis, and most commonly it's in the lower part of the pelvis or on the pelvic sidewalls. There's a couple of ways that we conceptualise endometriosis in terms of what the lesions look like and where they are located. So I tend to use this description in my head of superficial endometriosis, or endometriosis that affects the lining cells, called the peritoneum, endometrioma, which is when endometriosis affects the ovaries, and deep endometriosis by definition is deeper than 5 millimetres, but it possibly behaves as a different condition. When we start reading the fertility literature, there's a very old scoring system from the 1990s that looks at grading endometriosis, not based on the symptoms or the location, but based on the sort of impact it was going to have on fertility, and they labelled it grade 1, 2, 3, 4. And so grade 4 aligns most with deep endometriosis and or endometrioma. By definition, people with endometrioma will usually have at least grade 3 disease, and superficial endometriosis is most commonly the grade 1 and grade 2 disease, though it's not always that sort of cleanly split. These are just a couple of pictures showing different types of endometriosis, and these are peritoneal deposits. I would argue that there's potentially a deep deposit in under here, but you can see this is a bumpy or almost blistery type of endometriosis, and most of that would be superficial. And this is also probably superficial, but you can see it's a darker, more purple lesion, but it's affecting this layer of tissue called peritoneum. This is a different appearance to endometriosis. So you can see the sort of the way that the pelvis is all being pulled in. So these ligaments would, in a non-endometriosis pelvis, kind of be flapping down here, and this area of stickiness wouldn't be here. So this is deep endometriosis. Same here. And in this case, you can see, and this will go on to the fertility discussion, you can see the tube. This is a fallopian tube here. It's all sort of pulled in here. Now, I should have said at the start, there are some clinical pictures. I will try to give you a word of warning before they come up. I just don't have a lead as to what slide's coming, but I don't think there might be one more, but I do apologise if I've grasped anyone who's not feeling so comfortable looking at pictures. Diagrams though, so these are endometriomas. So this is typically called this chocolate cyst, and these actually live in the ovaries, and these become really important when we start to talk about fertility. Adenomyosis is, I guess, a pet love and pet hate of mine. So adenomyosis, think of it as the poorer cousin of endometriosis, in that if we don't have enough evidence and research and knowledge about endometriosis, we have even less about adenomyosis. And adenomyosis is when the endometrium, so this lining of the uterus, impacts in the muscle of the uterus, and can cause painful and heavy bleeding, and also has impacts on fertility. The most recent statistics that have come out only a month and a half ago, 2 months ago, now state that by the age of 49, 1 in 7 women, girls, and those assigned female at birth will be diagnosed with endometriosis. It's still taking an average of 6.5 years to be diagnosed. There's almost 900,000 people living in Australia with endometriosis. Many of you on the call will have had experiences firsthand with this disease. So it can be associated with heavy periods, painful periods, pain at other times in the cycle, pain with intercourse, bowel problems and fertility problems, fatigue, headaches, linked with mood disturbance, sleep problems, you name it, it's probably linked with this condition. All right, so we're moving now on to where endo has an impact on fertility. And I thought we'd just do a little bit of anatomy first. So this is a labelled diagram looking at the structures that are important in the female body for fertility. The first one, labelled 1, is the ovary, and this is where the eggs are grown, and those eggs have been there since the patient or the woman was a fetus in her own mother's tummy, or own mother's uterus. I should talk to everyone like adults. So those eggs have been there a long time, sort of paused in a state of immaturity. And then once a patient begins undergoing or going through menarche, those eggs will be recruited each month, and a dozen will get recruited, and one will become the dominant one for ovulation. The eggs are released, and then in this quite remarkable structure called the fallopian tube, that is actually a really beautiful structure. It's like a little sort of coral mopping up the egg. It gets pulled into the tube and travels along. Egg meets sperm along the tube. So fertilization, where sperm meets egg, actually occurs in the fallopian tube. And then as that fertilized egg, now called a embryo, travels along, that will move into the uterus, and the uterus is where the pregnancy needs to grow. The embryo will implant in the endometrium, and in terms of pregnancy, we now switch and call this the deciduate. And then the uterine environment sort of nourishes and grows the baby until it's time to be born, and this is the cervix. I've sort of cut off the rest of the structures there. Endometriosis can have some pretty wide-reaching effects on fertility on all these structures, and this is a nice diagram published in an article last year. So if we start over here looking at the mechanical factors, so it can impact on the way that the tissues work in the pelvis. So it can affect how those tubes work and how the tubes can pick up the egg. It can change the way that the tissue works. It can actually change the way that the muscle of the uterus works and can make fertility problematic in that respect. Endometriosis also causes chronic inflammation within the pelvis. So like a toxic fluid, for want of a better word, but not trying to be catastrophizing about it. But it releases compounds that can be toxic either to the developing egg within the ovaries. It can affect the quality and the quantity. It can affect the tubal environment. It can also affect the way that the sperm interact with the egg along the tube, and it can possibly affect the way that sperm functions, though that's a little bit more difficult at a research level. It can also affect, I guess, the chronic system or the systemic system of the patient, and it can affect their mood, their sleep. Chronic inflammation can have other effects in terms of liver function, vessel function. We've spoken about the impact on the ovaries. Endometrioma, or those cysts on the ovaries, can have even bigger effects than the thought of that peritoneal endometriosis. And me as a surgeon, sorry, I've just lost my lights in my room. That wasn't planned. The operations that we do for treatment of endometriosis can have an impact on a patient's fertility as well, and I'll go into that over the coming slides. The very act of having intercourse can be very painful and triggering for some patients with endometriosis. And so the idea that if I'm telling someone to have regular unprotected intercourse for a week around ovulation, that can be impossible for some of my patients. And so the actual act of having sex can be impossible or near impossible for many patients. And then this is up and down depending on where we're at in research, but the idea being that the actual endometrium that's in the right place in the uterus may be also in a state of chronic inflammation or not ready to implant an embryo, and so implantation doesn't occur. In terms of diagnosis, we've gone through this a little bit. A couple of webinars ago, we looked at how to get a diagnosis and what to look for and what we should be doing. So still to this day, the best, or what we do, whether or not it's the best, I guess we continue to argue at an intellectual level, but we make the diagnosis firstly based on patients coming to see us with a group of symptoms. Now those symptoms are commonly pain-based symptoms, but also as a fertility specialist, I think about endometriosis in every patient that comes to me with fertility problems. There is still a delay to diagnosis, and we'll talk about that a little bit in terms of what that means and the importance of thinking about endometriosis in the setting of infertility. Transvaginal ultrasound is still the mainstay for identifying endometriosis, though it still lets us down in terms of superficial endometriosis. That's not because people aren't doing a good job, it's just that we're looking for very small amounts of disease on a very thin layer of bladder. Pelvic MRI can also be useful, and we're in one sense very lucky that we now have access to that on the MBS, but it's not superior in many instances to ultrasound. We use MRI. I tend to use it more for deep endometriosis, particularly looking at the bowel, but it needs to be interpreted by someone who's very skilled in this area. It's quite a specialised niche of radiology. The same with ultrasound. Unfortunately, not all ultrasounds or ultrasound reports are created equal, and that's up to, I guess, an open discussion between your gynaecologist, your GP, and you in terms of how reliable the ultrasound is. We don't yet have a test that works well for superficial endometriosis. We are really working on it. We are trying to use saliva tests. We are trying to use, we're hoping to bring along a test that may measure electrical activity of the gut. We are trying at a genetics level, at an endometrium level, but we're just not there yet. So there is no perfect test yet to say someone has or does not have endometriosis, short of having an operation called a laparoscopy. I follow that statement, though, to say that a diagnosis is not always essential. And for my patients who aren't seeing me from a fertility point of view, it is okay to receive a diagnosis of possible or probable endometriosis, particularly if you're not trying to conceive at the time, because it still does allow treatment. I'm glad to see on the Endometriosis Australia website that the decision to have a diagnosis formalised by laparoscopy needs to be an open discussion, because it is an invasive test. You should be aware of the risks involved with laparoscopy before you decide to have this procedure performed. You can treat your symptoms, or choose to try to treat your symptoms with medications or alternative therapies, and you may be able to avoid a surgical procedure. It just gets a little bit tricky when you're trying to conceive, and that's what we're going to focus on now. If a patient comes to see me with probable or possible endometriosis who is wishing for pregnancy, it does change a lot how I manage their symptoms, because a lot of the treatments that we would use would be contraceptive at the time. I was asked to talk a little bit about preconception discussion, and I've put it in here, but now I've come to the slide and I'm not sure it's in the right order, but we'll go to that, and then I'm going to come back to focusing on the how of how to get pregnant if there are issues with pregnancy. But putting my obstetric hat on, so I work across gynecology, fertility and obstetrics, preconception discussion is really, really useful. And I think for anyone with a chronic disease, of which endometriosis is, I think it is a really helpful discussion. A lot of this can be done by your GP, but sometimes it should be done by a gynaecologist or an obstetrician. In general, when someone comes to see me to discuss pregnancy, we do all the basic things. So this is anyone, whether they have endometriosis or not. We look at lifestyle factors that may have an impact on conception or pregnancy, be that extreme exercise, contact sports, alcohol drinking, I don't know, just brainstorming a few things. Reviewing your past medical, surgical and mental health history and discussing what implications this might have for pregnancy. Addressing any medications that you're on and if these have any concerns for pregnancy. Reviewing if you've had any previous pregnancies or gynecological history. Ensuring your vaccinations are up to date. Discussing now genetic carrier screening and providing a referral. So genetic carrier screening, the baseline model, has been approved for full Medicare funding as of the 1st of November. So something that you can absolutely discuss with your GP or your gynecologist if you're planning a pregnancy. Discussing fertility and education on actually how to conceive, what your cycles look like and where your fertile window is. Ensuring that your cervical screening test is up to date and putting you on folate and iodine, ceasing alcohol and reducing caffeine, probably to 2 drinks of caffeine a day. In terms of endometriosis specific, so I've put in there previous pregnancy complications. Now, my area of research is looking at pregnancy complications in patients with endometriosis and adenomyosis. And at the moment, sort of watch this space, but it would be very important to, if you've previously been pregnant, to have the discussion about what complications occurred. They may not be related to your endometriosis, but at a preconception counselling point of view, it's still very important to know what happened last time. In terms of other endometriosis specific things, is duration. If you've been trying to conceive for a while, how long is that while? Where are you up to, and what can we do? Assessing, do we know that the tubes are working? So endometriosis can affect the tubes. Do we need to check that they're working prior to conceiving or prior to trying to conceive, or do we need to check they're working if you've been actively trying to conceive for, say, 6 months? What's your partner's semen analysis? Where when you're looking at trying to conceive, some people will actually, particularly people with endometriosis that's associated with painful periods or painful sex, will discuss doing a semen analysis early on. So essentially, so that you're not doing months and months of having cycles and experiencing pain only to find out that your partner has a semen problem and you were going to need assistance with fertility anyway. About 30% of infertility is related to the male or the male alone. And so it's an important thing to have in the back of our minds or at the front of our minds. And review symptoms that may prevent a patient from having regular unprotected intercourse. What to expect when trying to conceive? I think Nikki or Steph or Caitlin, I think you all asked me to sort of focus a little bit on this. I think first and foremost is to take away a little bit of hope from the talk tonight, that most patients with endometriosis will still be able to conceive naturally. It just increases the rate of troubles conceiving and the rate of needing IVF. The return of menstruation for those who've been on hormonal contraception or suppression can take a little while. Now, that might be a couple of months. It shouldn't be excessive. And I think if you've come off your pill and your period hasn't come back by the 3-month mark, it's probably worth speaking to your GP and definitely seeing someone if the period hasn't returned by the 6-month mark. It may all still be normal, but it is absolutely worth having the discussion. Your periods should go back to the same regularity that they were before you went on the pill. So again, if your period comes back, but it's really irregular, but when you went on it 15 years ago, your period was regular, then I would want you to see a gynaecologist. Hormonal fluctuations. So for people who've been suppressed on hormonal contraception, so be that the pill or the Implanon or Depo-Provera, all of a sudden people can experience the highs and lows of a cycle again, and for some people that can be quite triggering and quite challenging. So again, it's about monitoring the cycle, looking at those fluctuations, and if they're problematic for you, speaking to your GP or your gynecologist. Some people, their hormonal migraines will come back. For some people, they'll get sort of really nasty PMS symptoms leading up. So again, just being open and discussing those symptoms that have previously been well controlled. Having a discussion with your gynecologist about possible pain flare management, recognizing that to try to conceive naturally, you're going to possibly have a period, unless you're lucky enough to conceive the first cycle. You're going to experience ovulation and you are going to need to have sex unless you see us for intrauterine insemination. So it's good to plan and have a discussion of tactics with your treating team about what those painful triggers might mean and how you can manage them. And then looking at taking a bit of control into your own hands. I'm amazed by how good people are on cycle tracking apps. So many of my patients use them and love them. Other people will use calendars, temperature charts. So you can download apps like Flow or Natural Cycles. You can have a digital thermometer with 2 decimal place, so 2 numbers after the decimal place, and you can monitor your temperature through the cycle and look at how your temperature jumps after ovulation. And you can use LH urine tests to sort of monitor when ovulation is occurring as well. I put a few slides in very quickly. We've already seen this slide. So this is sort of the bits and bobs that the female anatomy needs to conceive naturally. This is going back to year 10 biology and looking at the menstrual cycle. And so what this talks about is these are the brain hormones here. They talk to the ovaries. And the ovaries start to go from little baby follicle frozen or asleep to waking up this follicle for ovulation. And as that follicle is waking up for ovulation, the ovarian hormones change. So estrogen climbs, and then after ovulation, progesterone climbs. And this is why you get sore boobs, a little bit of constipation, not feeling quite right in the second half of the cycle. What happens in the endometrium, or this is the lining cells of the uterus getting ready for implantation, these are responding down here. This is responding to what the ovaries are making. So this is responding to estrogen and then to progesterone. So this is a nice diagram that I use to explain those cyclical changes that are noticed. I put that there because it was the first picture I could find of a bed, but again, for natural conception, you've got to be able to have unprotected intercourse. I'm sorry, there's a dog, but he was kind of cute on there. And then the sperm have to be able to get there. The sperm have to be healthy and they have to be able to fertilize the egg. Looking at pain relief options while trying to conceive. Lots of patients don't want to be on anything while trying to conceive because of fears of impact on the developing embryo. All of these items have reasonable evidence of either no harm or no evidence of harm. With NSAIDs, so I've put there, it is okay to be using non-steroidal anti-inflammatories for your period when your period comes, because if your period comes, you're not having a period, you're not pregnant. If, though, you are uncertain if you are pregnant or not, you would do a pregnancy test before going on your Nurofen or your naproxen. Paracetamol is safe. Buscopan is safe in early pregnancy. You can probably still use your vaginal Valium or baclofen if you're using it leading up, particularly if you're needing to use it before or after intercourse. We probably don't want you being on vaginal Valium further into the pregnancy unless you've got sort of guidance with your obstetrician on that. Amitriptyline, I tend to say, discuss this with your doctor. The concerns about amitriptyline were probably brought to bear when we were using it as, or when it's used in doses for antidepressants, so 100 to 150 milligrams a day. When we're using it for pain, we're using sort of 25, 30 milligrams, and there's no current evidence that that causes any harm in the latest literature. Melatonin, 2 milligrams all the way up to 10 milligrams, you could keep using during your period. You could stay on your zinc, just check that your supplement doesn't have vitamin A in it. You might look at your dietary alterations, and if you've got nasty sort of a lot of bloating symptoms now that your periods are coming back, looking at what you can do with the help of a dietitian in terms of altering substances that could be particularly triggering for that. Continuing with your physio, and physio during pregnancy is so important, not only from pelvic strength, but pelvic coordination. And you're able then to build a relationship with your physio, which is helpful for after birth as well. You can use your TENS in pregnancy, so you can use your TENS trying to conceive. And then there's evidence in terms of relaxation, improving sleep, acupuncture to improve fertility, but also to try and assist with pain symptoms while trying to conceive. Unfortunately, there's no role for the usual hormones, like putting someone on the pill or using the Mirena. We can't use any of these while you're trying to conceive because they will actively stop you from conceiving. And so the latest guidelines from ESHRE and the RANSCOG guideline for endometriosis basically say there's no role for hormonal therapies in people who are trying to conceive. We do sometimes use the pill or other hormonal substances in an IVF cycle, so that's slightly different. But in the general sort of spectrum of using them, we have to bring you off these to spontaneously conceive. I was asked to put a few things like when to see a gynaecologist or when to see a fertility specialist. And probably at the top of that list is if you're worried and you want to see a specialist in this space, I think that is a really good time to say, to ask your GP, look, can you help me out here, or can you refer me to a specialist that you trust? In terms of basic numbers, I've put there, so this is the GP college teaching is for a person under the age of 35 trying to conceive for 12 months. If you're unsuccessful, go and see a fertility specialist. I tend to say with endometriosis, I would possibly like to see you earlier, and I'm happy to see anyone at any time of their fertility journey. It doesn't mean you're going to need IVF. It might mean that I'm going to say, look, everything's in order. I'll see you in 6 months if you're not pregnant. If you're over 35 and you've done more than 6 months of trying, I think it would be really good for you to see a gynecologist then. And if you're over 40, I think you should see a fertility specialist straight away. That, again, doesn't mean you're going to have to, people get really worried about coming to see me because they think I'm going to say you need IVF straight away. That's not the way fertility specialists work, or definitely not the ones that I know and work with. We want to work with our patients to achieve their fertility goals, but do that hopefully in the safest, kindest, most economic way and within what your, I guess, religious and ethical beliefs are. If you've got severe endometriosis, you know you've had severe endometriosis, but you've been really well managed with the Mirena and it hasn't been an issue. When you are thinking of trying to conceive, that would be a time where you would speak to your gynecologist about, you know, how long are we going to wait? Should we check that my tubes are working? What's my ovarian reserve, knowing that I had that endometrioma removed several years ago? If you've got a known genetic condition in the family that has a gene that is known and can be tested, then seeing a fertility specialist to see whether you want to go through the process of going through an IVF cycle to prevent passing on that gene to children. If you're having recurrent miscarriages, or if you're in a same-sex relationship or a single, sort of aspiring single parent. This is the list, and I guess you'll all have access, but this is a basic list of investigations that we ask the GP to do with the referral to see a fertility specialist, and I'm happy for Steph and Caitlin to share that as needed in a way that's helpful, but it'll be on this webinar as well. Imaging, so even if you've had a scan several years ago that said you had endo, often we'll repeat that scan to look at what the ovaries look like, where the ovaries are located in the pelvis, are there new endometriomas there, and what is the antral follicle count, which gives us an idea as to how many eggs are left in the basket. The slightly more accurate, or the more accurate test, is called the anti-Müllerian hormone. This is a test that costs about $80 in Australia. It's not Medicare rebatable. It doesn't tell you how fertile you are. It just tells you how many eggs are available. And it doesn't say you have 1,000 eggs left. It just gives us a number and we plot that number. And I'll say it again, it doesn't tell you if you're fertile or not. It just tells it is just a number. It can be, it'll be artificially lower if you're on, say, the oral contraceptive pill or in pregnancy, and it'll be higher if you have conditions such as PCOS. Patients can have PCOS and have endometriosis, so it's sort of this balance. And again, it's a test that can guide us in terms of how worried am I about a patient, say 30-year-old patient coming to see me, has been trying for 6 months and has had 3 operations with endometriomas in the past. I'm going to be quite worried that I'm going to do an AMH and find out that that is low. So again, it doesn't tell me as a fertility specialist exactly how fertile you are. It just tells me how many eggs are in the basket. In terms of infertility treatment, so this slide could be passed on to even just giving a talk on infertility, not just a talk on endometriosis and fertility. So the treatment needs to be based on age, what barriers there have been to trying to conceive, how long you've been trying, what sort of relationship you're in, is there a sperm issue, are you in a same your disease, what impacts or troubles are you having with trying to have intercourse? Is your partner fly in, fly out? There's no opportunity for timed intercourse at the right time in the cycle. So all of these sort of things that we have a discussion. Sometimes we need to use ovulation induction. Now, ovulation induction is not necessarily for endometriosis, but it may be that a patient is having an ovulatory problem in and around their endometriosis, so they've got PCOS and endometriosis. We can use fertility medications and intrauterine insemination. Sometimes we use surgery, and I'll go on to that. And sometimes we either do surgery and then move on to IVF, or sometimes we move straight to IVF. Check. Going all right time-wise. I will not be too much longer, guys. I think give me a wave if I need to speed up. Surgery is usually done keyhole surgery. We've got different methods to treat the endometriosis, and I encourage you to speak to your surgeon about these. But from a fertility point of view, one form of treatment is not necessarily superior to the other. In terms of indications, again, pain or troubles conceiving are indications for surgery. The role of surgery for endometriosis, this is a discussion really important to have with your gynaecologist or your fertility specialist. In terms of that minimal or mild endometriosis that affects the peritoneum, surgery can be an option. We probably need to do 12 operations for one extra person to conceive naturally with their endometriosis gone. But there is, level 1 evidence that surgery improves pregnancy or sort of fertility outcomes with mild endometriosis. In terms of endometrioma, we don't have the same evidence. Often we will remove larger endometriomas due to significant symptoms or concern regarding links to malignancy. But with small endometriomas, often we will leave them behind because of the impact on ovarian reserve if we remove them. And I guess close to my research heart is the fact that we really don't have great evidence on moderate and severe endometriosis, and should we do a laparoscopy before you try to conceive? Should we do a laparoscopy and you try to conceive? Should we delay the laparoscopy and move you into IVF? We don't know what the right answer is, and hopefully I'll be able to tell you, but it's maybe 5 years away or so. I've mentioned endometrioma. So anytime anyone is operating on you for an endometrioma, have the discussion. What impact does this have? No gynecologist is going to worry about a patient asking questions about their own health, particularly their fertility. So ask them, what impacts could this have on my fertility? What considerations should be had? Do I need to have this operation? Often we do have that open discussion, and the decision is that you will do the operation. You decide to do the operation because your pain is so severe, but it's that open discussion. We can undertake fertility treatments around endometriomas. It can make things a bit trickier. We sometimes need to use antibiotics, but we can do IVF around endometriomas. And we need to, I guess, rationalise and weigh up those risks versus benefits for the individual patient. This is direct from the ESHRE guidelines, sort of indicating that we really need to take an individualised and multidisciplinary approach in terms of how to approach fertility for the patient, and the same little thing. That was a plug for my research, but I won't waste your minutes on that. But that's a study you may be approached for, and many of you may be involved. So that's for people with severe endometriosis who are looking to try to conceive and trying to answer that question as to how much, if anything, does surgery help with that ability to conceive. And lastly, I thought I would look at fertility preservation, because this is a bit of a vexed issue. So we now live in a day, and it's so exciting, we live in an era where we can freeze eggs, and we can freeze them really, really well. 15 years ago, we couldn't freeze them well. We would freeze them and then we would try to thaw them, and they would become mushy and not very healthy. But we can now snap freeze them, and those eggs can be preserved sort of at the same quality that they were when they were collected. Now, researchers have been trying to work out should everyone with endometriosis, or everyone with endometrioma, or everyone with severe endometriosis, is there a benefit of freezing their eggs when they're young, say before they're ready to try to conceive, knowing that they're at increased risk of having fertility problems as older people, and not wanting to run into that issue of being older with reducing ovarian or oocyte or egg quality, and reducing oocyte quantity, number, and endometriosis. So, you know, the whole hand of things. We don't know yet, but again, it's one of those things that needs to be discussed with patients with endometriosis, and something that you could see a gynaecologist or fertility specialist to have that discussion. And I think Jim may have stepped through that a little bit at one of the webinars that hopefully people can look at. But that idea that we personally think that this is a really good idea for patients with, particularly with moderate and severe endometriosis, so bilateral endometriomas, those scheduled for surgery, those where conception is unlikely, or those, for instance, that have tubal factor disease who aren't ready to try to conceive, but they've had their tubes out because they were swollen, full of blood, not working. They might want to freeze their eggs when they're 29, not necessarily because they're ready to use them, but because their eggs will be healthier at that age than they will be at 35 when they come back. But at I guess, an economic level, and at a risk versus benefit, the evidence is sitting in equipoise at the moment. But it's something to have a discussion with your treating team, because I think it's a really important consideration for all patients with endometriosis. So I'll start to summarise, and then please hit me with questions, because it's such a big topic. Endometriosis is a very complex condition, complex in its pain symptoms, complex in its fertility. The impact on fertility is multifactorial. It's not necessarily just one sort of challenge in terms of fertility. We need to individualise the treatment to every patient that comes in. We need to offer often a combined approach with potentially changing lifestyle, medical therapies, surgical measures, and assisted reproduction. And we at JACE obviously firmly believe in a multidisciplinary approach, both coordination and discussion expertise from the nurses, and then the ability of those nursing staff to coordinate for patients to see someone who's going to be able to look after their symptoms and their individual needs. I've put a couple of resources there. They're not all fertility based. Some are focusing more in the psychological space, which is my very, very first research project as a junior medical student, was looking at the anxiety response in people going through fertility treatments. And so again, if you've had a chronic condition of endometriosis, and then you're lumped with the sort of fertility journey on top of that, that can be really tricky to navigate, and looking at those self-help and pain resources is useful. Endometriosis Australia, the Julia Argyrou Endometriosis Centre, and these are more focused on pain, but they're some recent good reads that you can have a look at. And I'm happy to answer questions.
Yeah. Hi, Sam. We're back. Thank you so much for such a concise presentation. Like we said, we're very, very lucky to have had you, and thank you for your time. We do have a few questions, so I'll start with the first one that's come through. The question was, what would be considered a healthy AMH range for someone that does have endometriosis?
Yeah, great question. We haven't adjusted the chart based on endo or not. I guess the concern is with endometriosis that if you have operations on the ovaries, that your AMH may decline faster than, I guess, the natural paradigm. I don't know whether I can share on here, but essentially the graph for AMH is age specific. So your AMH will decline over time. So we've got studies sort of gauging AMH from about the age of 25 or so, and it does decline over time and declines more rapidly in the later 30s. And so we tend to measure AMH in centiles, so sort of less than the 10th centile being more concerning at a fertility level. And remember, it doesn't tell me you're not going to have a baby, it just tells me you may have less likelihood with your own eggs, depending on how long you're going to wait. And so I can't answer with an exact number, but anything less than 10 for me at any stage as a fertility specialist, I start to go, oh, look, that might be, particularly if you're not actively trying to conceive, something that needs to be addressed. But equally, if you're having big endometriomas out, someone will often do an AMH and you'll be reassured by that, but it'd be something that possibly you should have a discussion to review in a year's time or so from that.
Thanks, Sam. The next question is, I have severe endometriosis, stage 4, with no endometriomas, and my specialist has said IVF will not be a viable option to conceive if I have trouble naturally. What are your thoughts?
The specialist said IVF wouldn't be an option?
Would not be a viable option.
Okay. I guess tricky without knowing the clinical details for me to, I think, give a very personalised answer on that. I wonder if there are, I guess I don't know why there would have been such a black and white answer. Trying to think. Yeah, I'm wondering why they would say there'd be no option based just on the grade 4 endometriosis. I guess if your AMH was really, really low or your age was very high, so a lot of clinics won't use your own eggs after the age of about 43, 44. And if your AMH is really low, it may be that they were saying, look, this might not be an economically viable point of view. Egg pickups can be very tricky in grade 4 disease to do vaginally, depending on where the ovaries are sitting. So that might have been another discussion, sort of we may have to pick up the eggs in a different way. But I'm sorry, I don't think I've got a clear answer without knowing all the ins and outs.
And I think another thing to consider is if you've been told something, you're always welcome to get a second opinion from another specialist as well. You know, if you are wanting to explore all of your options, that is something you can do. You can always reach out to a second specialist. Sam, we've got a few more questions coming in. So the next one is, does the delay in endometriosis diagnosis impact egg freezing potential in younger patients? How can this impact future fertility in patients with severe endo who missed the opportunity to freeze their eggs when they were younger?
That's a really well thought question. Thank you so much for that. Look, I think it's quite a vexed discussion because we don't fully understand as gynaecologists which patients' endometriosis will be progressive and which patients won't. So I guess that's the first thing, is that this 6.5 year through to 11-year delay in diagnosis may have far-reaching impacts if we think endometriosis progresses. But for many patients, it won't progress. It'll be a sort of a stationary or a slowly grumbling disease. But what we miss if we miss the diagnosis is we miss the ability to treat the symptoms. And that's why I think it's really important to switch to this, possible or probable diagnosis of endometriosis, particularly for patients who are waiting on the public system. In my public hospital, it can take people 2 years to get to my clinic and another 2 years to have an operation. And that could be 4 years of, even though they've got their referral and they're waiting and their GP has thought this could be endo, they're waiting a long time. So we should be treating the symptoms. When we look at the fertility, I think again it's having that discussion that the ability to freeze your eggs is your decision at any time. Now, often we won't do it in very young age 20s unless there's an obvious reason, chemotherapy or significantly reduced fertility reserve. But that idea being that the discussion can be yours very much to drive. The issue then becomes funding. So egg freezing at the moment for, I guess, all comers, so all comers without a diagnosis is deemed social funding. So patients are paying out of pocket for that cycle and that egg freeze. And that is costly for many patients. Whereas with the diagnosis of endometriosis, and again, this is evolving, it's not a blanket answer, but there's the potential that there will be public funding for egg freezing. Not there yet, watch this space. And for patients now with severe endometriosis in Victoria, we're looking at the public clinic at Women's as being able to do egg freezing, but Caitlin might know more about this than I do, but I don't think we're there fully yet. But I guess the answer to the question purely at a public health level is it would be really good to diagnose severe endometriosis early, not only from a symptomatic point of view, but if there is public funding for egg freeze, or when there is public funding for egg freezing, then that would be an option. But again, I think tacking on to what Steph said, that if you think you've got symptoms of endometriosis and you're not in the position to sort of be pregnant, either you're studying, you're unpartnered, you're waiting to buy a house, or the whole multitude, or just not ready, having that discussion with a gynaecologist and saying, look, I'm worried I have endo, but I'm also wanting to talk about preserving my fertility, having that discussion early. And it might be that you decide, great, I've got all the information, I'll come back and see you in a year or two, I'm going to manage my endo symptoms, and then I'm going to come back. If I still haven't met my life partner, then I'll look at coming back and freezing my eggs at the right time. And a lot of people sort of gift it to themselves. They put some money in their bank account each month, and they come back and use it after saving. So I hope that answers. It's a really, really good question, and I could go on at an advocacy level for hours, but it's a really important question. But I think the delay in diagnosis needs to be viewed as a potential that we could keep managing some of those symptoms and discussion about fertility, even if we haven't managed to formalise the diagnosis.
Thank you, Sam. That was really thorough. The next question is, how does endo affect the growth and development of the baby? And is pregnancy more painful due to some of the connective tissue being connected and sticky?
Great question again. I hope to have a really good answer soon, maybe not that soon. So there's been this boom in the medical research or the literature over the last 5 years, or basically since 2016, so 7 years, looking at pregnancy outcomes in patients with endometriosis. And I guess I'm very conscious of not wanting to create a sense of sort of catastrophe and fear, because most patients with endometriosis will still have very normal pregnancies and very healthy babies. But there's a growing sort of association between some of the pregnancy complications and endometriosis, but the studies are a bit flawed. Firstly, they use what we call a retrospective technique. So they're looking at the endpoint of pregnancy complication and looking back at whether a diagnosis of endometriosis has been made. And by doing that, we struggle to control for a lot of other confounders that make those risks more likely, such as age, BMI, whether people have had surgeries, what other medical conditions that they've had. So that's the first thing. The second thing is it would just be one of those things to ask your obstetrician, particularly patients with severe adenomyosis. There's probably reasonable data to say that preterm birth growth restriction, preeclampsia, high blood pressure in pregnancy may be more likely. Now, it's not an absolute. We're talking an increase of about 20%. So not 20%, 20% of 4%. So you're only going up by a matter of, a mere percentage or so increase of these risks. In terms of pain, pain is very interesting. I have many of my patients with endometriosis who say the best time, their best symptom control was actually in their pregnancies. But those who have a big pelvic floor muscle component may have a lot of flares of their pelvic pain symptoms. So again, it would be one of those things, the tissue, like the scar tissue from endo, actually decidualizes a little bit. So often it will not be a problem in terms of fixed tissue and not stretching. But it can be, I guess, an issue if there's other pain symptoms or pain syndromes in and around the endometriosis, sort of the endometriosis diagnosis. In terms of labour, we don't fully know the impact of endometriosis and adenomyosis on rates of caesarean section, but possibly the rates of caesarean section are higher. And people postulate that maybe it's a tissue, an issue with the tissue, that the actual labour mechanics may not be normal. But by and large, most people with endometriosis, I don't think it has an impact greatly on their mode of delivery. And again, it would be having that discussion, and this is the importance of preconception counselling and or early pregnancy discussion about what impacts could this have, where's the literature standing. I hope to be able to, publish things over the coming years that might guide people on where that is, but we're still working it out. But it's something you could absolutely discuss, and maybe just by discussion, then they'll do some extra growth scans and just monitor the baby's growth, and everything would be fine, but you would be nice and reassured.
Thank you, Sam. So I know that we're pretty much just at time, but if it's okay with you, I've just got 2 more questions.
No worries. I'm sorry I'm sitting in the dark. I hope people can still see me.
No, we can see you. We can see you perfectly. That's absolutely fine. Okay, so the first of the 2 is, can you develop endometriosis after you've had hormonal treatment when you are freezing your eggs?
Can I just clarify? So can the hormonal treatments of IVF or freezing eggs cause endo to grow?
Yeah, can it act as a trigger?
Yeah, we don't think so. So the current guidelines from ESHRE say that there's no evidence that ART hormones increase the, I guess, recurrence or growth of endometriosis. I will often have a little look at the size of the endometrioma. So say someone's got an endometrioma and I'm doing a fertility cycle, and usually it stays about the same size as well, which I find reassuring. I think, though, if you were to stay off your hormonal contraception for months and months and months around that fertility cycle, then yes, your endogenous or your internal hormones could change things. If you've got a Mirena in, we can do a fertility cycle with your Mirena, like an egg freeze cycle with the Mirena in. If you're on any of the contraceptive pills, we have to take you off it for the period of the cycle.
Perfect. I think that covers exactly what they were asking. And the last question is not as concise, but the general statement is the presence of pain a factor in fertility? So I know you did touch on that a little bit in terms of, if intercourse is painful, then of course that can get in the way of the process of conception. But any more thoughts on this statement or question?
I guess I could get quite broad on this. I'm just clarifying. So do you mean, should pain be a red flag for fertility problems, or is the presence of pain having the actual just presence of pain having wider implications for healthy conception?
They haven't exactly stated, so I would go with your instincts and what you think is the best way to answer the question.
Sorry, I'm drilling you guys back. So I think it's a really good question, because there's I'll go with the second my second interpretation first. We are busily working on, I guess, looking at the impact of endometriosis and sleep health and sleep hygiene, and sort of where mood, sleep and pain all entwine. And there's not great evidence, but some evidence to state the really important links between fertility and sleep. So when we look at people who work shift work or lots of night shift, the sort of disruption of circadian rhythms and healthy sleep, and the ability for sleep to drive down your inflammatory response and sort of coordinate your parasympathetic nervous system. So if we extrapolate from that sleep is important for fertility, and then we move in and we say, well, endometriosis affects the quality or can affect the quality of sleep, then yes, and we think that's by pain modulation, then maybe yes, then the actual presence of the pain due to endometriosis could have other implications. But I think that I wonder if I'm being quite tenuous in that description. The first interpretation of the question, just looking at now I can't even remember how the first one went. Using it as a red flag, absolutely. So if someone comes to me with subfertility, and I will always ask them about period pain, other pain, bowel pain, bladder pain, sex pain, and I think those should all be used as red flags for the possible diagnosis of endometriosis. And it would be in those patients that doing either exploratory imaging or laparoscopy may be, I guess, more worthwhile sort of investigating the presence of endometriosis. All my fertility patients will have an ultrasound, but not all my fertility patients will have a laparoscopy. I will have some patients turn around and say, look, I know I might have endometriosis, but fertility is my absolute priority here. I don't want to go through the risks of a laparoscopy. I the 1 in 1,000 chance that it goes wrong. I'm just going to move straight into fertility treatment, Sam, and that's fine. But yes, I would use pain as a red flag for endo could be the problem here.
Beautiful. I think that definitely covered, and I really hope that, no, it was wonderful, and I hope that answered the question that they were trying to get across. That's all we will have time for tonight, but on behalf of everyone watching and everyone that will watch the recorded session, thank you so much, Dr. Mooney, for joining us tonight. It's been exceptional, and I think that everyone would have got a lot out of tonight's session, and it's the questions that sometimes we don't know where to go to ask. So thank you for being such a warm presence and so open and giving of all your knowledge. And thank you to everyone that's logged on to watch this evening, and thank you to everyone in the background who's helped facilitate this evening as well. It takes a team. So if you would like to know anything further, you are welcome to get in touch with either, well, it'll be myself or Caitlin or our team here at the Julia Argyrou Centre. Our contact detail is on the screen. Look forward to hearing from you if you require our assistance, but all the best, and enjoy the rest of your evening. And thanks again to Dr. Mooney.
Thanks, everyone, and all the best.
Bye.